Good evening and welcome to Autism 207. Tonight's topic is Autism and Sleep Issues, Information for Parents and Caregivers. Our presenters this evening are nurse practitioners from Seattle Children's Autism Center. They are Karen Sporn, Dora Hall, and Caitlin Cotter. Before we begin, there are a few announcements. There will be time at the end of this presentation tonight for question and answer time. So please add questions to the comments section, and we'll try to get to those at the end. This session is being recorded and will be viewable online at Seattle Children's Facebook site immediately following this presentation. And in about 2 weeks, it will be permanently available on the Autism 200 YouTube channel. In fact, all past lectures are at this site. So just go to YouTube and search Autism 200 series. We currently have over 50 different presentations available for viewing. The Autism 200 next month is Thursday, November 18th, and the topic is Autism and the African American community. Also want to make a quick plug to send to remind anyone out there who's viewing this session tonight that our Autism 200 series runs year-round. We take a break in December, but the series starts again in January, and we're currently collecting topic ideas. If you have any topic ideas for the Autism 200 series, something you'd like us to cover, please put that in the comments section as well. Okay. So you're here tonight because you know children with autism can have sleep issues, which can be hard on both the child and their family. In this panel presentation, our speakers will discuss the importance of sleep, sleep problems, and their potential causes, and strategies to improve sleep for autistic children. Karen, Dora, and Caitlin, you can take it from here.
Okay, it looks like we are back on. Thank you everyone for being patient. One of the things that happens when we're all virtual. So I will get us started. I think Katrina talked about how this is going to work tonight. We're using Facebook Live. Please communicate with us through the chat function. We will be monitoring those comments for questions that we will answer at the end of our lecture presentation. Back one slide, please. Thank you. So the goal of this class is really to talk about sleep problems with consideration to children with autism spectrum disorder. Sleep is important for all of us, and hopefully this discussion will be helpful in giving everyone some understanding about sleep and sleep concerns, some of the causes and of those concerns, and some strategies for improved sleep. However, we also want to say if you are here and you have a child with autism spectrum disorder that is experiencing sleep problems, please talk with your provider about that, and hopefully some of the information that we give you here tonight will help you to guide that conversation. Next slide, thank you. So why do we care so much about sleep? I think we can all answer that in terms of if we've had a poor night's sleep, how that makes us feel. But why is sleep so important? Well, sleep serves many functions for our brain and our body. Sleep helps to recharge and reset our brain for the next day. Sleep is involved in reorganizing memories and new information that have accrued that day or in the recent past. During sleep, our brain deletes unnecessary information. And various hormones are released during sleep, such as growth hormone, which contributes to growing and repairing muscles in our brain and our body. So sleep powers our mind, restores the body, and fortifies virtually every system in our body. So pretty important. Next slide, please. So, what does it look like when children are not sleeping well? As adults, if we aren't sleeping well or we've had a poor night of sleep, we tend to feel sleepy and lethargic, and maybe we're kind of slow to move around. Well, this is not the case in children. Children that have poor sleep often do not present with daytime sleepiness, but rather we sometimes see the opposite of that. So we may see children that aren't sleeping well that have hyperactivity, or they have difficulties focusing. They may have difficulty regulating their emotions. They may be irritable. They may have problems with their memory. Poor sleep can affect kind of the immune system, and we may see immune system dysfunction. Children that are not sleeping well, we may see increased risk-taking behaviors. We may see social difficulties, and we may even see differences and delays in nonverbal skills. So when you look at this list of symptoms, poor sleep can really also be kind of look like and mimic other concerns, for example, ADHD. And it can be really just attributed to children not sleeping well. Next slide. So in order to understand what is happening when our children are having sleep problems, it's helpful to understand our circadian rhythm and a typical sleep cycle. So the circadian rhythm is our master clock. It's what keeps track of all of our mental and physical processes in our brain and body. And the circadian rhythm also controls our typical sleep cycle, which is a rhythm that is usually 24 hours long. The way it works is typically in the morning, there is light. And so the sleep-wake cycle in the circadian rhythm is based on light and dark. So morning light or sunlight will trigger our brains to release chemicals that will promote being alert and awake. And then we go about our day. And then in the evening or at sunset, the darkness will signal the brain to shut down that alertness and to release a hormone called melatonin, which helps to promote sleep. Melatonin is released in that evening time, and that helps the brain shift from a wake state to a sleep state, and then fall asleep. And those melatonin levels will drop in the early morning, which then signals the brain to wake up. And those melatonin levels will remain low throughout the day. And that cycle begins again with the morning sunlight triggering the brain and us being awake. So we all have a sleep cycle, and any differences in this cycle can affect our sleep. So our rhythm can be disrupted by medications, too much light, too little light, traveling and time changes, and as well as by several other factors. Next slide, please. So what do we know about sleep problems in children with autism spectrum disorders? Well, we know that sleep problems are very common. And actually, sleep problems are common in all children. But we know that for children with ASD, about 70 to 75% of children with autism spectrum disorder will have sleep problems at some point, compared with 45 to 50% of children without ASD. And the sleep difficulties that children with autism have tend to be more chronic in nature than those in children without ASD. So why is that? And that's something we're going to be talking about in upcoming slides, but it's thought to be a result of genetic factors. These are things like our genes, hormone levels such as melatonin, the sleep rhythm and internal clock is thought to be one of the factors, but then there are also likely a combination of other factors such as environmental factors and behavioral factors, medical factors, medications can affect sleep, and social factors. So we're going to talk in more detail about those concerns and the different kinds of factors in children in the upcoming slides. And with that, I will pass it over to Karen. Thank you.
Thanks, Dora. So now I'm going to talk about some of the common concerns that parents express related to sleep in kids with autism. So one is obviously trouble falling asleep, and that includes a delayed sleep phase. And the delayed sleep phase is actually pretty common for teenagers and adolescents. And this is when they develop a circadian rhythm that's just slightly longer than 24 hours. And this results in the delay of the circadian rhythm or the sleep pattern, the sleep cycle. And this is called the delayed sleep-wake phase disorder. And essentially what happens is that the teen's sleep-wake schedule is delayed, and then they are not getting tired during the day. They're staying up later, and then they're sleeping in. And so they aren't on that normal kind of light, dark cycle for sleep, and they turn into night owls. This obviously results in difficulty waking up in the morning, trouble falling asleep, and they just can't, they just are off. Other common concerns are waking in the night, and I have a slide upcoming on that. Resisting bedtime, challenging behaviors during the bedtime routine, trouble waking in the morning, waking up too early in the morning, but then being up for the day, which can cause challenges. Sleeping during the night, but not getting quality sleep. Sleep is restless, and maybe there's snoring involved. Next. So to talk a little bit more about night waking. So night waking is actually common in both children with and without autism. And it's actually pretty normal for everyone. But the difference is children with autism are more likely to have behaviors that are associated with waking up instead of being able to, kind of self-soothe themselves back to sleep. So some of the behaviors that we would see in kids with autism who are waking in the night are laughing, they're talking to themselves, they're playing with toys or objects in their room. They might yell out, they might be screaming. Some kids wander the house and it turns into a safety concern. They might attempt to access food or other things in the house, devices or other items. Next slide, please. So some of the causes of sleep problems could be related to these three items: medical, environmental, or behavioral. And usually it's really a combination of these three. And what we try to do is first rule out any medical concerns, if there are any. And then we think, can we go through the rest of the factors to see if there are any things we can identify and thus control? Next slide, please. So I'm going to talk a little bit about medical factors first. One of the medical factors that we can see in sleep challenges is restless leg syndrome. And what restless leg syndrome is typically distinguished by asking the question about a child or individual's urge to move the legs. And this is the primary symptom of this movement disorder. And it actually runs in families. So there is a genetic mechanism for restless leg. So if you have a parent who has restless leg, it could be that the child might be having the same challenge. Another medical factor might be obstructive sleep apnea or other breathing problems. So sleep apnea is common in children who have enlarged tonsils or adenoids, or children of any age with obesity. So that the children with enlarged tonsils and adenoids, it's most common in school-aged kids. Some of the symptoms that you might see that are associated with sleep apnea are snoring, gasping, snorting during sleep, nighttime wakings, restless sleep, and excessive sweating. Another symptom is bedwetting. It's more common in kids with OSA, obstructive sleep apnea. Also, if kids have OSA, they often are more inattentive, kind of like what Dora talked about. They're struggling with their sleep at night, and they look more inattentive. They're irritable. They have trouble focusing. They have behavior problems or hyperactivity during the day, or they can have daytime sleepiness. Some other symptoms that you might see during the day if a child is having OSA is nasal obstruction, mouth breathing, poor inattention or irritability like we talked about. And typically how we diagnose OSA is through a sleep clinic, and a sleep study is completed. Other factors could be illness. So, if a child is sick, he or she may sleep less or more. They might have nasal congestion. They might have allergies that are interfering with sleep. Pain is something that we also think about, and it's really something to think about or consider when you have kids who are non or minimally verbal, or who have difficulty communicating what their pain might be or what their wants or needs are. So we really want to make sure that we're thinking about this as a possibility. So this could be chronic or recurrent pain. It could be like symptoms of reflux, which would include heartburn, spitting up, chest pain, coughing, or throat clearing. It could be ear pain, especially for younger children. And, when you lay down, ear pain sometimes gets a lot worse. It could be headaches, toothaches, itching, maybe abdominal or tummy pain. So those are things that we definitely want to consider. Also, we can't forget about anxiety and depression. And anxiety, including separation anxiety and depression, can be really common causes of sleep and insomnia in children. And then the lack of sleep worsens the mental health concerns, and it kind of creates this vicious cycle. Seizures can also be a medical factor related to sleep. They can occur overnight, and they can present as movement. I do want to mention, though, that there are other sleep disorders that have movement as well. So like restless leg would have movement, sleepwalking, but we do think about seizures sometimes as a medical factor. And then medications, like what Dora talked in the previous slide, medications or substances can impact sleep, such as ADHD medication. A stimulant medication, for example, might make sleep more difficult. And then non-stimulant medications might make kids drowsy or sleepy. Next slide. So some medical causes are easy to identify and address, but others do require specialist or lab testing. So this could be, like, for example, restless leg syndrome. We know that it can be caused by low levels of ferritin, which is the storage unit of iron in our bodies. And when you have low levels of ferritin, this can cause a disorder, and the restless leg syndrome. And so you can treat it with iron supplementation. So in order to figure out if you're insufficient or deficient in this area, we would want to draw a lab first. Thyroid function can play a part in sleep. So if a thyroid disorder such as hyperthyroid can make kids have trouble with sleep, and hypothyroid can cause excessive sleepiness. Vitamin D has also been associated with poor sleep. Next slide, please. So I'm going to talk a little bit about environmental factors. So where does the child sleep? Is an important question to ask. What's the temperature of the room? Is it dark enough? Or is the child afraid of the dark? And does the child need a little bit more light? Are there noises that are bothersome, such as living in a louder neighborhood or living in an apartment complex? Is there a fan or an air conditioning unit that's noisy? Or maybe white noise is needed for the child. Does the child share a room with a sibling? I know this is a common issue, right? And so this can certainly impact sleep. Are textures bothersome, like the fabric of the pajamas or the sheets or the blankets? Does the child feel comfort from like heavy pressure, like a weighted blanket? Or does the child's sleep environment have stimulating activities? This is a big one too. Is there a television or a laptop? Is there a tablet or a cell phone or video games? Because this can certainly impact sleep as well. So in autism, sensory needs is a big deal. So textures and sounds can impact a child in his or her ability to sleep. Certain textures can relax or arouse, and that could be disturbing child's sleep. And then also, taking into consideration the noise level or the visual stimulus. Those are all factors that would play into that environment. Next slide, please. So behavioral factors, some of the common concerns might be bedtime refusal or resistance, taking a long time to relax and wind down, or wanting a parent to come in and out of the room and intervene often. So when does the behavior truly become a problem? Well, there's some degree of bedtime resistance or insomnia in most children. And oftentimes it's transient, meaning, it kind of comes and then it goes. To be truly considered a sleep disorder, the symptoms must occur at least 3 times per week, persist at least 3 months, and interfere. Okay. So we're going to talk about behavioral factors. There's a slide on this. Screen time, it does in fact make it harder and longer to fall asleep. So the light from the screens deactivates and turns off the melatonin in the brain, what Dora was talking about in a previous slide, and it fakes the brain into thinking that it's daytime, and then the whole sleep cycle is disrupted. So we really are concerned about screens if that's a part of bedtime routine. Balanced activity during the day. So sedentary activity during the day is associated with trouble falling asleep, whereas physical activity reduces the time that it takes to fall asleep. And this has been a big concern over the past 18 months with the pandemic. I'm hearing families that are coming in to see me, and they're concerned about, decreased activity. Their kids aren't going to school. They aren't in PE. They aren't getting out running around the playground. And we've all wondered how much that really has impacted sleep as well. Diet can be a factor. So like we talked about iron storage, if a child has limited diet, then there might be a low iron storage, and that can cause restless sleep. And we know that in lots of children with autism, limited diets are more common, and so they might be more at risk. Sugar intake can play a part. Caffeine can certainly play a part. So the effect of caffeine in the body typically stays for 3 to 5 hours, up to 12 hours. So that can certainly cause a child to have a hard time falling asleep. Hunger. So like, is the child hungry in the nighttime, or did the child eat too big of a meal right before bed? That could impact sleep. Naps during the day and time in bed. And what I mean by that is children typically need at least 4 hours between sleep periods in order to build up enough sleep drive again. So if a child is napping, the child needs to kind of stay on the regular daytime nap schedule. And naps should be in their bedroom as much as possible. And they need to avoid naps as they get older unless they're sick. Because too much time in bed can make it harder to sleep. And time in bed, if you have time in bed that exceeds their sleep needs, this could potentially result in a problem with the sleep bed. So like the child might not associate the bed with sleep. And then that leads to additional problems. So you want to try to make sure that the bed is just for sleep and not other activities. And then there's habits. So is there something in our routine that's accidentally reinforcing or making the behavior happen more. So this could be like if a child is having trouble falling asleep, could be associated with a parent or family member staying with the child until they fall asleep. And yes, we do this to try to help our child calm down, but then it might make the child dependent on this to soothe back to sleep. And then if the child wakes in the middle of the night, are they going to need the child to be back in their room to help self-soothe? And so we start thinking, how can we promote independence so that the child can self-soothe without the parent there? There's also attention for stalling behaviors at bedtime. I think we've all been through this, where kids are stalling and they're really seeking out parents' attention. Well, how can we avoid giving them this unwanted attention so they don't consistently repeat that behavior? Well, we start thinking about implementing a consistent response that just kind of extinguishes or kind of like eliminates that unwanted behavior. Next slide. So again, what medical, environmental, or behavioral factors might be contributing to your child's sleep problems? So this is something that we would ask you to think about. And it could just be helpful to take some time to consider these factors for your family. And I also want to point out that every child and family has unique needs, and there is no universal sleep plan. Sometimes we wish there would be, but there really isn't, just because every child is so unique, as is the family dynamic. So with that, I am going to pass it over to Caitlin.
Great, thanks, Karen. All right, so with all of that helpful information from Dora and Karen there, where do we start? So really the first step there when we have sleep concerns is to first try to identify the specific concern. And this can be tricky sometimes because there might be more than one thing going on at once. So really trying to figure out what is that priority concern, what is most interfering for your child. And that might be waking at night, trouble falling asleep, restlessness. Maybe they seem really sleepy or hyperactive during the day. So what is that priority concern that we have? And then once we've identified the problem, or really that main concern, what are the realistic goals and expectations for sleep for your child? And this is also dependent on their age. So we want to know how much sleep is normal for your child based on their age. And we know that younger children require more sleep than adolescents do. And so we want to know, does the family have realistic expectations for how much sleep this child should be getting? And does the family routine and schedule allow for the child to be getting as much sleep as recommended? And then what needs to change there to be realistic to kind of fit our sleep goals into our schedule? We strongly recommend considering keeping a sleep journal. If your child does have to go to see like a sleep provider or really talk to anybody more in depth about sleep concerns, then having that sleep journal is so helpful to help identify some patterns in what's going on with sleep. Sometimes just having that data in front of us to be able to see like what time we went to bed, what time did we actually fall asleep, what time did we wake up, and really anything else that's going on throughout the day even that could be impacting sleep. So generally just having that information there can be a helpful place to start. And I have an example of that coming up in a couple slides. And then, of course, practicing some good sleep hygiene. And we'll talk all about what sleep hygiene is on the next slide. Great. Ready for the next one? Great. So sleep hygiene. You may have heard the term sleep hygiene before. Sleep hygiene is really all about what is recommended to get the best sleep. So what does our research tell us that, what can we do to make sure we're doing everything we're supposed to set us up for a good night's sleep? But one of the first things that we think about is that sleep hygiene really is like an all-day event. So it really starts in the morning that we can try to focus on what can we do to improve our sleep. And that can start with early morning sunlight, whether that's just opening up the blinds or walking outside for a little bit. And that goes back to what Dora was explaining about the melatonin and the sleep-wake cycle, and how that will turn off when we realize it's becoming morning. And so it helps our brain know that it's time to start waking up when we see that sunlight. Exercise, and as Karen was talking about, we need to feel tired enough before we go to sleep. So are we doing enough activity and needing that rest? Are we feeling like we used our body enough where we have to get that restorative rest that we need? We recommend limiting caffeine and sugar. As we mentioned before, caffeine really is so variable. And so really for children, if we're having trouble with sleep, eliminating caffeine and sugar really close to bed or any time in the afternoon is a good place to start. Avoiding screens before bed. And I know this one can be tough because it's certainly not meant to be a punishment or any kind of repercussion for a child. But that screen, that light before bed is just really telling our brain that it's daytime, that it's not meant to go to sleep. And so as comforting as screens can be sometimes to watch a show or something before bed, trying to do that maybe like at the beginning of our bedtime routine or at least an hour before bed is a good place to start making some changes. And then we want to implement a bedtime routine, which we'll talk a little bit about in a couple of slides, with calming activities, something that helps wind down and tell your body it's time to get ready for bed. We recommend really anchoring our bedtime and our wake-up times every day. And that can be really challenging on the weekends or vacations when it's time to sleep in. And that feels really nice, but we do know that when we have that big variability in the times that we wake up, like on the weekends compared to the weekdays, that can really alter our sleep-wake cycle and kind of mess up our whole cycle there for the coming days. So the general recommendation is to not sleep in more than about 30 to 60 minutes more than you would on a weekday or a school day for children. And then, of course, we want to consider sensory needs. As Karen mentioned, this is really important, especially for children with autism, because we want to consider, is the environment cool enough? Is it dark enough? Do we need noise, or maybe is noise bothersome? So consider what your child needs specifically. All right, ready for the next slide? So after we've implemented some sleep hygiene and kind of identified our problem, then we can consider maybe some different behavioral strategies that we can try. So maybe once we've ruled out if there's anything medical going on or what's going on in our environment, we can take a try at some of these behavioral strategies. So one thing that we commonly recommend is to use a visual schedule. So a visual schedule, for example, of a bedtime routine of all the steps kind of written out or in pictures of exactly what is supposed to be done in your child's bedtime routine can be really helpful. And that, for one, a lot of children, especially in autism, may be visual learners, where seeing that visual cue is a lot more effective than being told what to do. It can also help the child be prepared for transitioning. So what comes next in the bedtime routine? What's our next activity? So having that visual schedule there can help with those transitions as well, which we know challenges with transitions is a core symptom of autism. So the visual schedules can really help to support that. And then we also use some bedtime passes. I have a picture of what a bedtime pass is coming up. And basically, it's kind of a system where your child can exchange this bedtime pass, kind of like a ticket, for whatever they need to come out of bed for. And bedtime passes are helpful for kids that kind of frequently come out of bed for like that third glass of water or one more hug. So this is something that can kind of keep that incentive to stay in bed a little bit. Because if they do stay in bed, maybe you can try to give them a morning reward, something that can give that positive reinforcement to stay in bed overnight. And for this, we recommend really multiple like small rewards that are immediate. So giving rewards kind of days later or even later in that next morning might be too late for your child to really associate it with that good night's sleep. So kind of right in the morning, something that can be really immediately rewarding for them. Checking in is a strategy that can be used also if your child frequently gets out of bed and is looking for attention or looking for something. And this is when parents kind of very neutrally come in the room without any excitement, just checking in, letting your child know that you're there. And this really prevents your child from feeling like they have to come out and see what's going on because you're doing that first. Another strategy is slowly transitioning to your child's own room. And this is, of course, if they're co-sleeping with you or in your room when you really want your own space, or maybe the opposite when they are when insisting that you sleep in their bed with them for them to fall asleep. And all of these are much easier said than done, of course, but one technique for this would be maybe like having a sleeping bag on the floor or a cot or something where the child isn't physically in your bed. And you can kind of slowly move them further and further into their own room, or vice versa, kind of slowly losing that time with a parent or a caregiver before sleep. Delayed bedtime with gradual adjustment. This is really helpful for those teenagers, adolescents that Karen was talking about that have some trouble with that delayed sleep time. And so this is kind of about meeting the child where they are. So we really can't expect somebody to go to bed at like 9 p.m. if they have been going to bed at like 1 in the morning. So by adjusting our bedtime gradually by about 15 minutes, it can help kind of slowly make those changes. And this really helps kind of make the changes less abrupt, more gradual, and help that sleep-wake cycle kind of normalize so it's not as much of a drastic change. And so this might mean that you're up at like 1 a.m. trying to do our bedtime routine, but really meeting them where they are and then slowly moving that earlier and earlier can be helpful. And a couple things to note is, forgot one there. The brief and boring nighttime interactions really means just be as the least exciting as you can be for your child around bedtime after their routine. So nothing that's going to get them really energized. After we do our bedtime routine, it's very minimal interaction, very neutral and brief. And things to note here is to expect something to get worse before it's going to get better, which I know is a little daunting to say, but children test boundaries. That's normal. And so we expect them to be resistant to change when we make some changes to our kind of family dynamics and our routines. And so it's normal for kids to recognize when you put these new limits or new behavioral strategies in place that they're going to test them a little bit. And so it's our jobs to be really consistent in how we approach this, because the consistency there is key when we experience this post-extinction burst. So kids can expect that I'm really not going to get anything out of this behavior, no matter how far I push it. All right, next slide, please. Okay, so this is a picture here of a bedtime routine. And this is just one example of a bedtime routine. Your child's bedtime routine may look really different. Bedtime routines are really important to individualize to your specific child. So what is going to be calming and relaxing for them? In general, a bedtime routine should start the same time every night. And that's because our bodies really amazingly kind of can predict when we start getting ready for bed. If we do the same things every single night, we'll start to get to know, like, oh, this is what we do before bed. So I'm going to start releasing melatonin and get sleepy. And so by having that really consistent schedule can help our bodies just get in that rhythm much easier. We recommend that a bedtime routine lasts about 30 minutes or so. Anything that goes beyond this or beyond definitely like 45 minutes can kind of prolong bedtime. And so really try to keep it to that 30 minutes or so and pick about 3 or 4 activities that are calming for your child. And then when the bedtime routine ends, should be followed directly by sleep. So after we do these 3 or 4 things, we're expected to try to fall asleep. So this particular example here, take a bath, put on PJs, brush your teeth, read a book. These are all examples of calming things, especially reading a book before bed. And so something like taking a bath, maybe if taking a bath really excites your child and that's something they love and become really energized during bath time, maybe we put that at the beginning of the routine, like here, so that we get it out of the way so we can start calming down. Or maybe if it's just way too exciting, we do that in the morning. So kind of play around with it and figure out what specifically is peaceful and calming to your child. Okay, go to the next slide. So this here is an example of a bedtime pass. This one is from Autism Speaks, and so you can find a whole bunch of them online, or you could even create your own with your child at home. Useful for like school-age children, or when we can understand that concept of, if I pass this in, there might be a reward for it. So the idea is that we can kind of use this as like a ticket system. So if your child comes out of their room, they give you the bedtime pass and tell you what it's for. So it's 1 visit from a parent, 1 drink of water, a hug, something like that they're seeking from you. And then if they don't use this pass overnight, maybe we get a reward in the morning. And so just trying to find a positive way to make it kind of a fun activity for your child too. All right, next slide, please. This is an example of a sleep log. I know it's kind of small and hard to see on the screen here. Pretty much the information that we like to collect when we're having trouble sleeping would be what time the child went to bed. So what bedtime do they have? The time that your child actually fell asleep. Did they wake up at all overnight? And then did they have any events overnight? Any sleepwalking or restlessness, anything at all that you've noticed? How was their eating during the day or their diet? Did they nap at all? Did they seem like they got good sleep? So maybe they were sleeping, but it seemed pretty restless. So are they getting a poor quality of sleep and just don't seem well rested in the morning? And so really just writing down anything that's associated with sleep here so that we have a place to start to look at. And sleep logs can be really great too for documenting progress, because sometimes it's hard to know if something is working, if it's slow progress. So having this documentation to look back on and see how far we've come to can be really helpful. All right, next slide. So one thing that we'd like to note too is just do not expect it to change out, to do everything at once. Don't expect everything to change at once. Have patience. These things take time, and it's really easy to say, but it's really hard to do, and it can be really hard to be consistent, especially when everybody is tired. So have patience and know that these things can take time. So, and it's of course different for everybody. So we can give you all of these tools, but finding what works for you and your family and your schedule and your specific child and their needs can take time to try out different things. So have patience. All right, next slide. Okay, so we won't focus too much on medications, but families often do have a lot of questions about medications for sleep. So we want to touch on them briefly here. One over-the-counter supplement that we talk about, we've mentioned a couple times here, is melatonin. So we've talked about melatonin so far in terms of the natural melatonin that we have in our bodies that's involved in that sleep-wake cycle. So you may be aware that you can get some melatonin over the counter at your drugstores or Amazon. And so this is a synthetic melatonin, kind of like a melatonin you can take to try to supplement what's already in your body. And so we know that the kind of research here for all of these medications, and including melatonin, really there's no medications that are FDA approved for pediatrics for trouble with sleep or insomnia. And so we really like to use medications or supplements such as melatonin with more chronic sleep disorders. So when we've tried these behavioral strategies, and we aren't quite seeing the progress that we'd like, generally we say give it a try for a solid month or so with these behavioral strategies before we try some medication. With that being said, we certainly acknowledge there are times of crisis where we're really not getting any sleep, or there's a change in sleep, or there's other stressors going on. And so certainly it can be appropriate to try things like medications or melatonin. For melatonin, we generally recommend to take it about an hour or so before bed. And the typical dose ranges from starting about really low at about 0.5 milligram to 1 milligram. And we generally increase that by about 1 milligram or so, with a typical dose being around 3 to 5 milligrams. But of course, talk to your child's provider if you're interested in starting that or you think it might be helpful. There's generally, melatonin is generally well tolerated, and no known serious adverse effects with melatonin. Some common adverse effects might be headaches or daytime sleepiness. However, it's generally well tolerated, but just to acknowledge that it is not FDA approved, so it doesn't quite have the regulation that medications that are FDA approved do have. The rest of these medications on this list, clonidine, guanfacine, trazodone, and gabapentin, are prescription medications. Clonidine and guanfacine work similarly. They're in the same class of medications. Clonidine is used more commonly for sleep, and it is the most common medication that is prescribed for sleep issues. It was originally developed to be a medication to treat hypertension, but was found to be more effective for children with ADHD or attention issues, but also helpful for sleep onset, so falling asleep. It's not as helpful for staying asleep. That tends to be a little trickier to treat than that falling asleep concern. Guanfacine, as I said, is a little similar to clonidine. We don't use it as often for sleep because it's not as sedating, but of course it really depends on the person and how the medication affects them. Trazodone is one that we use. Generally, we would try melatonin, clonidine first. And then gabapentin is another one that we might use more so for like a restless leg syndrome with sleep, with that restlessness that we talked about earlier. But of course, we would want to make sure there's no medical reasons for that restless leg first. Another thing to consider here is medications for anxiety or depression. And I think this speaks to like really trying to identify that underlying reason for trouble with sleep. And so if we're having trouble with sleep because of anxiety, worries keeping us up, worried about school the next day, or maybe depression, those are things that we would want to treat in itself. So treating that anxiety or treating depression, giving a medication for that, or really giving that the attention it needs, helps sleep at the end of the day. So really thinking of other health problems, mental health considerations too. Great. Next slide. Great. I think we had one before that for any questions. go. All right, so I think at this time we'll open it up to any questions, and I think we might have already gotten quite a few in the comments there.
Yes, we do have some questions in the comments. Thank you, Caitlin, for that portion. So we will kind of, we looked through some of these and we'll take them one at a time and answer them to the best of our ability. There was a question about melatonin. Is there data on the risks of long-term use of melatonin in kids with autism and significant sleep issues versus the rewards of them getting sleep with it? That is a great question. And the short answer is no, we do not have good data. Melatonin has not been well studied in children, especially long term. As Caitlin talked about just recently about melatonin, what we generally see is that the side effects, the side effect profile is very mild overall. One thing that can sometimes happen with some kids that use melatonin for a long time is they can need a larger and larger dose to a certain extent. This doesn't happen with all kids, but that can sometimes happen, and we don't have any good data to support going higher than around 9 or maybe even 10 milligrams of melatonin in a child. So this is something that what we do is we talk with families about kind of the risk of not sleeping well versus the risk of taking melatonin. How is the child tolerating it? As we mentioned in this talk, the risks of poor sleep are great as well. So it's something that is an ongoing consideration and discussion with your child's provider around using melatonin. Caitlin or Karen, do you have anything to add to that? Okay, great. I think Karen was planning to take one of the next questions.
Yeah, I thought I would answer to the best of my ability the question about night terrors, which is a question that we get a lot, and it's a great question because night terrors are just kind of this unusual thing that happens. And I don't actually know the answer, and I guess I'll ask Caitlin and Dora if there's a higher rate of night terrors in autism. I haven't heard that. I do know that it's quite common in kids, and I do know that it tends to run in families. So if parents had night terrors as kids, could be that it's more common to have a child with night terrors. They typically start, I think, around age 3 is the kind of the age, and then they go into childhood. And they're different from nightmares in that they happen at a different stage of sleep. So I think the child is probably in a deeper sleep when the night terror occurs, and thus it's harder to wake the child up. And most of the time, night terrors don't really have like a specific cause as to why they're happening, and they're typically not dangerous. They're not dangerous, but they're scary, right? Because the child might be thrashing and screaming and hard to wake up, and the parent is like, "Oh my gosh, what's happening?" But what we typically say is, it's not dangerous. Don't try to wake the child up, just try to calm the child, because if the child wakes up, then the child might be up and not able to get back to sleep. You want to make sure the child is safe, not thrashing, falling out of bed. Helping the child just kind of ease back into sleep is the best strategy. Now, what I will say also about night terrors is they could be associated with other things, possibly. So like sometimes kids with night terrors might have like restless leg, which could be like causing the disruption somehow, or, sleep apnea, like what we talked about. And so I think if they're occurring a lot, and you're worried, then talk to your provider about it and say, listen, this is happening. I'm afraid, it's scary. Most of the time it's nothing. There's nothing else happening. But, then you might be taking data around like how long they're, or how many times a week the night terrors are occurring, kind of like using one of those logs. And then you and your doctor or provider can determine, would it be worthwhile to do some further investigation about other things that might be contributing? Do you all have other thoughts or feedback on that?
No, I think that was great.
I think oh, sorry, go ahead, Kate.
Yeah, I was just going to say the kind of differentiator between like the sleep terror or like a nightmare, just to reiterate, would be that a sleep terror, they're really not aware that it's going on. And then, as Karen said, focusing on that safety piece and trying not to wake them and leading them back to bed is the general recommendation.
Yeah, oftentimes kids won't remember the sleep terror the night or the morning after, whereas they might remember a nightmare, So
yeah, that's exactly what I was going to say, is that the night terrors are really alarming and frightening for parents, but for the kids, they don't have any memory of them in the morning. Okay, let's see. Let's find our next question here. Oh, there was one quick question about do we see a correlation with night terrors and melatonin dosage? I have not seen that correlation. No, there are a few kids, when they start taking melatonin, may have nightmares as a side effect. It's a rare one, but if that happens, our recommendation is to discontinue the melatonin, but nothing related to night terrors. I said nightmares, right? Not night terrors. So no correlation between night terrors and melatonin dosage. And I think we also had a question on long-acting melatonin. So I think Caitlin had talked about melatonin being a good medication to use for help with falling asleep, but not a great medication for staying asleep. So one question was about a 4-year-old with ASD staying asleep. And the question is around trying extended release melatonin. I would say, so we are here to kind of give general recommendations. So our number one recommendation with any of these questions that are raised is please talk to your child's provider around this. There is an extended release melatonin, and we do try it in some children to see if that will help for staying asleep. I don't know, I think I can ask Caitlin and Karen what their experience has been in using that. It would be a trial to see if it does help for that waking up for the staying asleep portion, and not just the falling asleep at the beginning of the night.
Mm-hmm. The one thing I will say is that the extended release or timed release, the child has to be able to swallow a pill. So that is kind of a big factor for younger kids, because it's the release happens over time, and so it's not typically like a gummy or that it's like an actual pill that the child has to swallow. I have had some families who have had more success with the extended release in terms of like helping with the duration of sleep, but again, not a lot of, I haven't actually had a lot of families, say, oh yes, there's a huge difference. But yeah, that's been my experience.
Mm-hmm. Great point, Karen, about that needing to be able to swallow a pill to take any medication that is extended release. Okay, I think along the lines of melatonin and medications as well, there's a question about a child who takes clonidine 1 hour before bed, but it still takes him a while to fall asleep. So would it be okay to give melatonin as well in addition to clonidine? Certainly in our practice, we sometimes do use more than one medication. We always try to start with only one medication at a time and not throw two medications on at the same time, because then it's hard to know what is doing what. But certainly there is some indication to utilize possibly a melatonin and another medication such as clonidine. And I would recommend that you talk to your provider about that for your particular child.
Yeah, I agree with that, Dora. And we'll say that clonidine too can be, sometimes you have to find the specific right dose for your child too. So talking with your prescriber of, do we need to make any changes with that? And then, as Dora said, making one change at a time to know kind of what is working and what's not.
Great, thank you, Caitlin. Okay. There was a question a little bit earlier on asking about sleep study and what age is it recommended to do a sleep study. That is a great question. And the answer to that is there's no specific age to do a sleep study. Not every child that has some challenges with sleep will need a sleep study. And the recommendation to have a sleep study is usually based on exactly what is going on for that individual child, what the concerns are, how long it's been going on, the potential medical issues that are causing or contributing to the sleep issues. And that would be a discussion between your provider and you, depending on your child. There are a couple of things to note about a sleep study. So there isn't an age recommendation, but children have to be able to tolerate certain things in order to be able to go through a sleep study. So a sleep study is done in the hospital. So the child will need to be able to be away from their usual routine and spend the night at the hospital to do a sleep study. There are also sensors that are placed on the child that don't hurt at all, but they are placed on the body, on the scalp, on the hands for night, so that data can be taken during the sleep. So a child has to be kind of be able to tolerate that, having those on, and sometimes they're that a child that can practice that at home. But those are probably some considerations, much more so than a specific age recommendation. You know, if Caitlin or Karen, you have anything to add to that one?
I would just say, if your child does, I mean, if it is indicated, if you get to the point where you're talking with your provider or sleep medicine and it is indicated, there are resources, I think, in a lot of hospitals that kind of help kids prepare, and kids with autism. There are like social stories and lots of ways that you can practice with your child. So definitely inquire about those things, if in fact you get to that point, because there are certain resources and supports that can be really helpful to practice and have kids get ready.
Okay, let's see what other questions are coming up here. We're just sorting through these in real time. Let's see, suggestions for nighttime wandering. Caitlin or Karen, would you guys like to take that one?
Yeah, this is a good one, especially, and not a good one, but commonly seen in autism here at our clinic. For wandering, the first thing that comes to my mind is safety, especially if it happens, when everybody else is asleep in the home. And so really the priority of just how can we keep this child safe and in their bed, and considering, if their bedroom is upstairs, do we put a gate at the top of the stairs, or how can we give some positive reinforcement to really stay in our room? Because with wandering, I worry about, falling down the stairs or getting into unsafe cabinets or leaving the home. And so making sure we have like locks on our doors and alarms and things just around the home where we can be aware if that's going on. But happy to hear if Dora or Karen have anything to add to that.
Okay, there's a question about the perfect hour to go to sleep and the numbers of hours of sleep. That is also a great question. There are recommendations on approximate hours of sleep by age. I was going to try and see if I could pull those up to put into the chat. And in terms of a perfect hour to go to sleep, I don't know that there is a perfect one. There's, certainly a number of hours of sleep that children should have based on their age approximately, and then kind of taking that time and thinking about what that means in terms of when they have to get up either for school or daycare, and also what does the afternoon and evening look like for your whole family. So there are lots of factors, but I will try to find, let's see, I don't know if Caitlin, you had a link in one of your slides with the recommended hours.
Yeah, let me see how we can share that.
I wonder if we put it into our area that it can be put onto the Facebook Live by the AV team.
Let's see.
Maybe. Oh, there it is. Thank you, David.
That's great.
So I think it was put in there.
Perfect.
By David Eaton, our colleague. Thank you, David. And no, those are guidelines. So taking that as a starting point and then talking, figuring out with your family and your provider what works best for your individual child.
And generally, I like to think of it too as like the younger the child, the more sleep that they'll need. And as we get older, we need a little less. I think kind of just school age kids, I tend to think of like 10 hours or so being ideal, but give or take depending on schedules. And then if we're a little younger or older.
Okay. Are there any other questions that we did not answer or keep? If there are more questions, we are still here, and feel free to put any more questions that you may have into the comments, and we'll be able to read them. Great questions so far tonight. Thank you for those questions.
Yeah, really great questions.
Okay, we'll just wait another minute or so.
I just saw a comment that said, "I'm sad I missed this." It's actually going to be posted later. It will be available to view, I think, on our website. Is that where it will be?
I think it's going to be on Facebook Live right after we're done with this. It will be available to view on Facebook, and then also on our website and the Autism 200 YouTube channel. So definitely take a look at the information whenever you can at your own pace and your own time. Yep, and I think for our YouTube channel, it will be available in about 10 days, but Facebook Live will be available right after we finish here. And while we're waiting just to see if there are going to be any more questions, we also wanted to just remind everyone about next month's Autism 200 series, which will be on Thursday, November 18th. And the topic is going to be autism and the African American community. So we hope to see you at that one as well. I don't see any other questions for now. So I guess we can end a little bit early. Oh, there's maybe one. Okay. Let's see. Okay, so there is a question, I think, from the parent that missed this, who has children who have difficulty sleeping. I definitely suggest that whenever you can, at your own pace and your own time, go and see the information that we provided in this event tonight. And then should you have further questions, definitely speak with your child's provider about any further questions you have for your specific children. Karen and Caitlin, anything to add before we say goodbye?
I think that's it. Thank you so much for joining us tonight. We appreciate it.
Yes, thank you.
Yeah, thank you very much, and have a great rest of your evening.